Okay, and the professors and colleagues, and it's my honor to introduce some experience on the topic of the surgical management of the complex MCA aneurysms on behalf of the Professor Zhu. And oh, something wrong with my PowerPoint. Sorry. And in China, and most young colleagues now deal with the regular unruptured aneurysm using the interventional therapy now because it's fast and minimally invasive. And from the 2002 and to the 2023, there's many clinical trials want to discuss whether the craniotomy or intervention therapy is better when dealing with the aneurysms. And what about the MC aneurysms? And several years ago, we think the best strategy is to perform the clipping using the craniotomy, and especially for the hematoma over 50 milliliter or the subarachnoid hemorrhage with vascular spasm or the elder patient who cannot afford the dual antiplatelet therapy. And now, in 2022, there's also a clinical trials, and we are also looking forward to the results of the MC aneurysm surgery. And the world is changing, and just as I showed, the web and the contour and the next the many interventional device usage and put the bifurcation aneurysm forward. And also, this is the Piconers 1 and 2 and used in the bifurcation aneurysm implant. And anyway, the anatomy of the Sylvian fissure in the MCA is very important. And some young patients think it's easy, but the anatomy variation is very difficult. And about 11 years ago, and Professor Zhu and I has published an article discussed the complex middle cerebral artery aneurysm. And we set a new classification based on the angio architecture and the surgical strategies. Until now, about 20 years later, and we also published the 3 articles also discussing the MC aneurysm strategy, surgical strategies 1 year ago. On somebody says the aneurysm, MC aneurysm is easy, but I think it's hard, especially for those complex MC aneurysm. And we also want to illustrate this topic from the classification based on the angio architecture. And this is the M1 segment aneurysm. I also want to begin with a case. And it's a 26 years old male patient, and the chief complaint is lower limb weakness for more than 3 weeks. And from the CTA and DSA, we see the left M1 segment big aneurysm. And also we can see the CT scanning, we can see a lesion located in the left Sylvian fissure, and also the MRI T2 image, and with the mixed signal lesion. And this is a picture during operation because it's large and also located in the left MC M1. We perform the trapping and we use the radial artery as a graft to perform the STARA-MC bypass. And now the patient's fine, and this is a post operative CTP. And from the perfusion, we see the left hemisphere showed the low perfusion. But the patient was fine, and we also found the slight right foot weakness, and the muscle strength reached grade 5 minus and no aphasia. And this is the post-operative DSA. We review it, and the bypass was patent. So now the bypass moved from the ECIC to ICIC. There's still some obvious advantages of the IC-IC bypass. For example, the shorter bypass graft for the fluent blood flow. And also we can avoid the muscle flap and the bone flap affect the donor and the graft. But there's also some limitations. For example, in IC complex aneurysms, the EC-IC bypass showed more advantages than IC-IC bypass, and the IC-IC bypass could not be performed in some aneurysms. Just for example, the PCP3 segment aneurysm or the basilar artery aneurysm. And what about the MC complex aneurysms? I searched in PubMed 1 year ago, and there's most of the neurosurgeons who could choose the ECIC bypass and seldom for the ICIC bypass in the complex MC aneurysm. Several years ago, we performed several bypass based on the ACA1 as the bypass donor. There's still advantages. The first is the interposition short graft. Only 5 centimeter RA could be used as graft, and no anastomosis time limitation for RAA1 and two-side anastomosis because of the ACAM artery composition. And there's some limitations for the A1 as donor. The first is the experienced anastomosis technique was used because the corridor of the operation was very narrow and deep and deep. And also some perforators will sometimes from the A1 segment, and sometimes the ACAM artery composition assessment before operation was needed. And this technique was not we just performed the first time. In 2018 and 2020, and Professor Lawton has published 2 articles to show this technique. And after we performed 7 cases, we also published 2 articles to illustrate this technique. And let's move to the case 2. And this is a application of the A1 donor bypass in a ruptured aneurysm. And it's a 27 years old female patient, and chief complaint is sudden onset headache and vomiting 1 month prior. And in the local hospital CT report, we found the ICH. And after admitted in our hospital, we reviewed the CT, and most of the ICH was absorbed. And this is the CT scanning. We see a little high density lesion was located in the left Salvin fissure. And this is a high resolution vessel wall MRI. And we found the aneurysm wall was enhanced. And this is CTA reconstruction. We can see the left MC-M1 segment dissection aneurysm. And we also review the CTA. And this is left ICA and the AP position and the lateral position. And this is some pictures during operation. And we use the radial artery as graft, and we perform the end-to-side anastomosis to the M3. And another side of the radial artery, we perform the RAA1 end-to-side anastomosis. And this is a bypass. And the ICD showed the bypass was patent. And this is short video, and because of the time, let's skip it. If we have enough time, I will show it. And after that, we perform the aneurysm trapping. And also, we perform the intraoperative DSA. The aneurysm was better, and the bypass was patent. And this is the post-operative CT scanning. And also, let's move to the another bypass. Just as the many professors mentioned, the STA-MC bypass is the most classic and the most effective method in the MC aneurysm surgery. And let's move to the next case, and it's STMC bypass used in a recurrent aneurysm. And it's a 19 years old patient, and chief complaint is sudden onset headache and vomiting 1 day ago. And during in emergency department, and the Glasgow score was just 8. And we can see the CTA, and it's aneurysm with hematoma. And in local hospital, the neurosurgeons perform the aneurysm clipping using 2 regular clip. And during follow-up, 1 year later, and we found its recurrence. So we performed DSA, and this is AP position and oblique position. And for this patient, we perform the aneurysm trapping. This is an illustrative figure. And this is the first time, and we found the recurrence. And in the second time, we performed the aneurysm trapping, and we used one STA to perform the STA-MC bypass. And this is a post-operative CTA, and this is a bypass. Another patient's fine. And this is the STA-MC bypass used in the recurrent aneurysm. And also, it can be used in the graft-related complications, and can be used as the salvage therapy. And this case showed a 58 years old male patient, and the chief complaint is aneurysm found by health check 1 month ago, and no positive findings in physical examination. Then from CT scanning, we found the right MC aneurysm, and this is a high resolution vessel wall MRI, and this is a contrast image. We can found the mixed signal intrasac, and we perform the DSA. The DSA shows the right MC M1 segment aneurysm, and this is 3D reconstruction. And this shows the right ECA and the 2 branches of STA. And we also want to perform the A1 RA and 2 MC bypass. And this shows the A1 to RA and this RA to M2. And during operation, the ICG was fine and the bypass was patent. Well, we performed the intraoperative DSA. The patent was occlusion. The bypass was occlusion. So we back to the operation field. We found the thrombosis in the anastomosis point, and we remove it and perform the anastomosis again. During operation, the ICD shows the bypass was also patent. Well, when we perform the intraoperative DSA, the bypass was also occluded. It's weird. So we have to perform the STMC bypass. And after that, this is last time intraoperative DSA, and this is the ECA, and this is a post-operation CT scanning. We also found some ischemic stroke located in the right basal ganglion. And this is the operation video. Well, after 3 months of follow-up, the patient was fine because of composition from other vessels. So sometimes the STMC bypass can be used in the graft-related complications, and also can be used in salvage therapy. So what about the bifurcation aneurysm or the M2 aneurysm? Let's move to the next case, and it's a 60 years old female patient, and the chief complaint is intermittent dizziness for 1 month, and also no positive findings in physical examination. And this is a preoperative MR and the MRA, and we found the right MCA bifurcation aneurysm, and also we found the mixed signal intra aneurysm sac. This is DSA and the 3D reconstruction. We can see the two right M2 branches derived from the aneurysm sac or even the neck. So we set a strategy. If we can directly clipping or perform the aneurysm morphy, we must use the intraoperative DSA to confirm there's no remnant. And if we cannot perform the direct clip or aneurysmorphy, we need to perform bypass. This is a picture during operation, and this is aneurysm. And we perform the proximal occlusion and also two branches of M2, and we punctured the aneurysm. And we use two regular clip to perform the aneurysm clipping. And this is the ICG during operation. We found the aneurysm was clipped. Well, during the intraoperative DSA, we found a remnant here. And this is three positions to show the remnant. So the intraoperative DSA is very useful. So we add two milliclip, and we review the intraoperative DSA. The aneurysm was totally clipped. And we also show three position of DSA. Another patient file and also a short video. And a similar case, 62 years old patient, and the chief complaint is intermittent dizziness and headache for 2 weeks. It's similar, right? The aneurysm was located in the left MC M1 M2 bifurcation. And also two M2 branches derived from the aneurysm neck. And this is a high resolution vessel wall aneurysm and the more mixed signal intra aneurysm sac. So we also cite preoperative strategy. Just like the previous case, we want to perform the aneurysmorphy or perform the direct clip. If failed, we need to perform bypass. But we can say this patient's M1 and M2 length was enough. So we have the third strategy. If we can, we could resect and remove the aneurysm and perform the reconstruction of the bifurcation. So this is the pictures during operation. And this shows the aneurysm and M1 and two M2 branches, just like this. And after we remove the aneurysm and we perform the end-to-end anastomosis first and leave part of the anastomosis point and then perform the end-to side anastomosis to reconstruct the Y-fashion anastomosis. And this is during intraoperative DSA. And this is the AP position and the lateral position. And this shows the anastomosis point. And we also detect the blood flow of the M1 and the two M2 branches. And this is 1 month after operation. We review the CT and the MR, and this is T2 flare and DWI. And this is the CTA. The triangle shows the arrow shows the anastomosis point. Another patient's fine. So it's two similar operations and bifurcation aneurysms, but the bypass strategy was totally different. In some cases, we must perform the STMC bypass prior, just like in this case, and it's a 64 years old female patient, and chief complaint is severe headache for 5 days. And the CT scanning shows the high density lesion in left salivary fascia, and this is MR. We found the mixed signal lesion. And before operation, we also performed the DSA, and this is left ICA from 3 position. And this is a 3D reconstruction. And we can say it's M1, M2 bifurcation and near the M2 MC aneurysm. So this is pictures during operation. And after we split the salivary fascia, we found the aneurysm neck and the dome was with severe atherosclerosis. So we want to perform the direct clip, but we failed. And then we want to preserve one M2 and M1, and to perform the M3 side-to-side anastomosis first, just like this. But we still failed. We cannot preserve the bifurcation. So we have to perform the double barrel STMC bypass first to guarantee the M2 distal blood flow and resect the aneurysm. Well, fortunately, and the length of M1 and M2 was enough for the side-to-side anastomosis. So under the protective STMC bypass, we perform the side-to-side anastomosis. And this is a video, short video. And this is a post-operative DSA. And now the patient's fine. There's no hematoma and no the infarction. So what about the M2 bifurcation to M3 or distal? Maybe the proximal occlusion works. The next case is a 45 years old male patient, and chief complaint is repeat headache for 1 year. And this is a CT scanning. It's a very large aneurysm with calcification, maybe with thrombosis. And this is MR with mixed signal lesion. And this is DSA. The DSA shows the right MC distal, M3 distal aneurysm. So we draw an illustrative figure to show the strategy. And the aneurysm neck was located in the M3. So we just perform the proximal occlusion. And this is pictures during operation and the post-operative CT scanning. And this is post-operative DSA. Another patient's fine. The composition was enough for this patient, so we just perform the proximal occlusion. But what about the extremely complex MC aneurysms? Just like this case, it's a tandem aneurysm, MC aneurysms. And in this case, we perform the staged surgery. This is a 57 years old patient and with chief complaint of sudden headache for 1 day. And in physical examination, the Glasgow score was 13, and the bilateral muscle strength was grade 5 minus. And this is pre-operative CT scanning and MR, and we can see the high fissure grade subarachnoid hemorrhage, and we found 2 left MC aneurysms also with mixed signal. And this is the first aneurysm, and this is the second aneurysm. We found the mixed signal intersect. This is a pre-operative DSA. And this is left ICA. We can see it's a tandem MCA aneurysms. And one is from ICA and one is it was located in the left MCA. And this is left ECA. We just mentioned that we always need to preserve the two branches of STA. And this is the right ICA. After compressed the left ICA, we can see the composition from the contralateral ICA. This is a left MCA M1 segment aneurysm. And we also perform the 3D reconstruction to show the aneurysm structure clearly. So the before operation, and we set a strategy, and it's a very complicated tandem aneurysms. So in first stage, we need to perform the ECRA MCA bypass like this to reconstruct the distal left MCA blood flow. And meantime, we will perform the left ICA occlusion. And in the second stage, we want to perform the aneurysm trapping using the interventional calling. So this is a picture during operation, and we split the cell vein fission, expose the aneurysm and the M1 and the 2M2, and we found the obvious atherosclerosis in the normal artery. We found the anastomosis points and to perform the RA and M2 bifurcation and to set anastomosis. And in the next incision, we expose the ECA and also found the anastomosis point and perform the RA to ECA anastomosis. And after that, we perform the ICA ligation and a short video. And this is the post-operation CT scanning. During operation, we remove the bone flap to avoid the post-operative edema. And this is a post-operative CT scanning. The bypass was patent, while the left MCM1 aneurysm was also there. So about 9 days later, and the patient was fine, and we review the DSA, and this is the right ICA angiography and the lateral position. And from the left ECA, we found the bypass was patent, AP position and the lateral position. And we also merged the two 3D reconstruction to show the structure more clearly. So after that, we set the right ICA approach using guiding catheter and using one echelon 10 microcatheter to rate the left MCA aneurysm across the ACAM artery complex and set several coils to perform the trapping. And this is a post-operative DSA. And now the patient's fine. And we have several take-home messages. And the first is I'm saying aneurysm surgical strategy must be based on the location. And every I'm saying aneurysm was totally different. So the individual vascular structure must be judged before operation. And for us in our hospital, the high resolution vessel wall MR will be performed before the on-rupture DSA, and especially for those complex DSA. So the HRMRI always show the more information about the aneurysm wall structure. And the next is for our young colleagues. The low brain pressure means better operation corridor, and we always need more anastomosis space. And just as the cases we show, the hybrid operation, the intraoperative DSA, always can ensure there's no remnant and bypass patency. And for the next message is the STA should always be preserved for salvage therapy. And when the ICS bypass failed, it's very useful. And last but not least, for the extremely complex the MC aneurysms, the staged surgery maybe is a better option. Okay, thank you.
Thank you for this comprehensive overview and complex cases, but also nice example on how with using all the tools that we have available, you can, with imagination, resolve a lot of these very complex puzzles. I leave the stage now to Professor Bojanowski to wrap up the discussion, show some cases for discussion, and then conclude the seminar.
Do you hear me? Yes?
Yes, yes.
Can you see my slides?
If you can share your screen.
Done. Is it, do you see it? Do you see my slides now?
No, we don't see your slides.
Mamma mia. I share it.
Maybe if you can unshare and then try to share again. And
desktop. It says allow Zoom to share your screen, and I say yes. Okay, open your system preference. Is there a reason why it's not working?
Imad, if you're still on the
yes,
line.
I'm here, but I think it's privacy from his computer, I guess.
Okay.
Oh, I'm surprised because I have already done that with that computer. Okay.
You can try if you can email me the presentation. I can see if I can open on the screen and then I can advance the slides for you.
Okay, I'm going to do this right now. I will use WeTransfer maybe because it might be part of the videos might be heavy.
In the meanwhile, I'll scroll through the chat and see if
sorry about that. Huh?
There was a question about how to dissect and open adherent sylvian fissure in a patient with years old and past history of bleed. And I think Dr. David mentioned that there are situations, especially in young patients, and as you proceed from distal to proximal, more proximally, where the fissure can be quite tight, but in that situation with the Yazardel technique from the inside out, once you have a corridor down, you can gently put traction on the temporal and frontal lobe and identify and proceed with under high magnification. In a patient with the prior history of bleed, it is true that the arachnoid is thickened and the planes are stuck, but sometimes that also acts as a protection because the thicker arachnoid at times protects you while dissecting around the vessels and the aneurysm itself. Carlos, do you want to add some other? There is. I remember you always used to talk about the water dissection technique, and that's actually very helpful. It's just after you open a small nick in the sylvian fissure with the syringe, inject under relatively high pressure some saline. It helps to open up the places.
Yeah, it helps, in terms of blasting the arachnoid apart from each other. But what I had answered the person directly, but basically, some fissures, let's be honest, are just impossible. Even Yassergill, if you look at his classification, he called the post-meningitic, the post-subarachnoid, what he called a grade 4. It's essentially almost impossible to split cleanly. And I think what you were saying is probably the best technique. Sharp, get deep inside, try to find that plane and separate it. But I think at some point with some of those more difficult ones, you're just going to have to accept that you're going to be subpeel at some level. And I tend to err on the side of I'm going to be subpeel, try to do it on that superior temporal gyrus, which, Roberto Heros, one of my mentors, used to argue that that was a nice way to split the fissure, to go through the superior temporal gyrus, to get deeper and then work your way out from there. I prefer to just preserve brain, obviously, but in some of these difficult situations, that's just, I don't think it's avoidable.
Giuseppe?
Yes.
Yes, soon you will receive the presentation via WeTransfer in your email.
Okay,
It's 90% now. And it's done. You should have received that.
Okay. Yeah, I have here my email open. As soon as I receive, I'll. One other comment is the previously coiled aneurysms. Professor David shows nicely the technique of opening the aneurysm and removing the coils. If there is an adequate neck, and we can discuss what that might mean, I found it very useful in those situations to direct clip the aneurysm using a fenestrated clip, even when there is a coil right in the vicinity of the neck. I don't know if you have also.
Yeah, so I guess I didn't make that point. My primary gestalt is not to remove the coils. So I always try to clip primarily and just ignore the coils. But as you noticed, frequently there's a shelf, they won't close, or they're going to push you down to the point where you're occluding the parent vessel. So in those situations, then I open the aneurysm. And what I do is generally just mobilize enough, get them away from the neck and clip. There are some situations where I have to remove them completely, but I try to avoid that if I can. So I agree with you. Just do what you need. And if you don't need to, just leave them alone because it's actually better.
Now, you also mentioned that you really use liberally temporary clipping.
Yeah.
I've always been, I always wonder, because often when you remove the temporary clip, you see that on the vessel there is the impression of the temporary clip. And have you ever had any problem where besides the length of the? It's surprising how really you don't have any problem besides the length of the temporary clipping, by just the use of the temporary clip, even adjacent to perforating vessels. Because let's face it, when you do MCA aneurysm, that temporary clip, there are always lenticular striates that are adjacent to that temporary clip. So,
Yeah,
but
I've not had any issues with the vessel being injured by the temporary clip. But I think the only times I've gotten in trouble were, frankly, early in my career when I was overzealous and left them on too long. You know, and I had some ischemia. You have to kind of respect the numbers that Hunt Bajer and Duke put out years ago. They really do hold. And of course, keep the blood pressure up and do your neuroprotective strategies. And I always try to avoid any perforators kind of being incorporated. But yeah, other than the length of temporary clipping, I've not had any issues with the clip itself.
I guess, Giuseppe, your main message here is, again, exposure is very important. And before you replace a temporary clip, we have to have a well-exposed MCA, and we have to look for these perforators. I guess this is your main message here, no?
yes, and continuous temporary clipping versus intermittent. Do you have any strong feelings?
If the clipping is going to be prolonged, I'm realizing, okay, I'm on here a little bit too long. I'll take it off and let the brain reperfuse. In fact, that was my research project when I was a resident in my research year. I did a study on rats where I had 60 minutes of continuous occlusion of an MCA versus 6 10-minute periods with 5 minutes of reperfusion. In my simple little study on rats, I showed significant difference of protection, less volume of infarct with the intermittent than the continuous. So I've always just subscribed to that. Again, the data is, you know, soft.
And in your practice, how do you decide? How do you advise patients in terms of indications for surgery versus consideration for endovascular therapy for an MCA aneurysm specifically, since this is...
I'll be honest with you. Like I said, I'm not terribly impressed. So age, comorbidities, general health. First, does the aneurysm need to be treated? You know, I have many elderly, unhealthy people who come in with small aneurysms. I tell them, leave them alone. There's nothing to do here. If the aneurysm needs to be treated and they're very unhealthy and you really worry that you can't get them through a craniotomy and recovery in a reasonable situation, then I'll speak with my endovascular colleagues, or in a rupture situation where poor grade, unhealthy, old. My new patient population here in North Carolina tends to be very unhealthy. And so I've had my colleagues partially coil and see how the patient does, and then I can always go back and fix it, you know, later. That's kind of my view. And you know me, I'm not a zealot. I am a true, I work well with people who do endovascular, and I work with Insub Choi and so forth. I think it has a role. In the MCA specifically, though, I still feel that is a surgical aneurysm. But everything has a place. So I think you have to individualize it based on all of those factors.
Michelle, I'm sorry. They are telling me that I've not received the email yet, and
I have the message, the opposite message. I have the message here that you have received it. Is it not your email?
There is let me see. I'm on my phone and on my computer, so I will eventually will, but there is a lag time, especially if there are attachments with the Mayo firewall, I think. So, but we can, and you know, we have gained quite a bit of experience with clipping previously coiled MCA aneurysms. Have you had any experience with the new entity, the previously web? I've heard some colleagues at meetings saying, "Oh, the web is very compressible." We clipped our first web recurrent, and I didn't find it as easy as, as some colleagues had made it sound. But basically we face the same issues that you face with previously coiled aneurysm, is that you have this rigid structure
Right.
close to the neck that really complicates things. We were able, again, with the fenestrated clip, tandem fenestrated clip, we were able to manage. But I have been told, though, it's very compressible, but that was definitely not our experience.
I'll be honest with you, I have not had a web yet. I always worry about those situations. Though where I have encountered, the difficulties is with the flow diverters, the pipelines and the surpass being in a vessel. I had an ICA bifurcation aneurysm. I think I've shown it to you, that was initially coiled, recurred. Then they put a pipeline and the patient got in-stent stenosis and the aneurysm was still there. And basically Waklu had no more options and he gave it to me. And the pipeline went from the carotid at the skull base all the way up to the MCA. There was no way to have temporary control. So I had to open the neck just in case, because you don't want to put a temporary clip across a pipeline or a flow diverter because it won't reopen. It'll be done. And what struck me, I did a bypass to protect myself, opened the neck, and then I was able to mobilize the coils and get the aneurysm clipped. But what struck me was the appearance of the blood vessel itself. It looked diseased. It's interesting. The outside looks like a necrotic, yellow, friable vessel. And that argument about, the healing versus the degradation after you put a flow diverter, you can actually see that in the vessel wall. And I guess that's why if the degradation beats the healing, you end up with those ruptures that we saw early on in the experience. But it struck me how the vessel looked.
Michelle, you have any experience with clipping previously aneurysms previously treated with the web, or
Not with the web.
Mm-hmm.
Not with the web.
Any advice you have for dealing with the previously coiled aneurysms?
I think when the aneurysm is small and there is a small recurrence, I usually wait, especially if the patient have never bled in the past. I just make sure that before I suggest any surgery, if I can put a clip on that aneurysm, because sometimes you don't need a very large neck in order to put a clip in a previously coiled small aneurysm. For large aneurysm, it's another problem, because you might have a recurrence with the coil at the neck, and this is more difficult, and everything has been said. I think you need then to open the aneurysm to remove the coil. And I agree, as less as possible, just what you need in order to put your clip. I operate a few patients with very large aneurysm, including basilar aneurysm with a lot of coils and with these inflammatory reaction compressing the brainstem, or with brain edema, especially with very good results when you remove you open the aneurysm, you remove all the coils in this situation, and then you close the aneurysm. I had this week a special case, a patient with I don't know if you ever heard about the NICE syndrome. The patient with this, I think it's nickel allergy.
Mm-hmm.
So the patient has this brain swelling, intermittent brain swelling, according to the doses of steroids, and it's very difficult for this patient. It's very difficult to treat, and the problem is that I cannot remove the aneurysm.
Mm-hmm.
Sacrificing because there is no recurrence of the aneurysm, so without sacrificing the vessel and maybe doing a bypass. But I have to think about that because it's a very complex ACAM aneurysm.
Yeah, you're referring to this condition of non-ischemic multiple enhancing brain lesions that we see likely not that frequently in patients after endovascular treatment. And the question is, though, if those lesions are related to the presence of the coils, or they are a sequel of the original procedure where some microembolizations occurred, and which led to, we have definitely encountered a few of those over the years. And you're correct, you stop the steroids and they recur and they become they'll become symptomatic. So let me do this. I'm forwarding an email from one of my students, and we can see if we can, because I still do not have, but I sent you an email with the link that you can download directly to a Mayo computer.
I'm really sorry about that.
That's fine. It's it's one of the issues of being on online, but so
drop link, is that you? Yes. So I just can, yeah. Okay.
Carlos, any it looks like for in terms of complex aneurysms, we have moved over the past 20 plus years away from high flow bypass in most cases, I would say, especially for cerebral artery aneurysms, and learned that often the STA is enough in many situations, especially when you are trying to replace a single branch. What has been your experience? How do you think about that? And
yeah, I think this comes from Fadi. Fadi showed all the flow studies that a good STA is enough. It used to be when I was a resident, they would say, oh, the maximal you'll get from an STA is 30 cc's a minute. And the reality is you can get double, triple that sometimes. You're right. Early in our careers, it was the vein, then it was the radial artery. I've gotten to the point where an STA is plenty. The only times I've used high flow nowadays is if I'm taking the carotid completely and, the patient fails a balloon test occlusion. But I think a good STA is plenty. And I think Fadi really laid out the groundwork for that.
And another point that, again, I wanted to reemphasize from your presentation is that we have so many tools nowadays that allow us to watch for perforator compromise of flow. I train, I'm old enough that I trained at the time where the intraoperative Doppler was the only tool. So I know it's not perfect, but I can, I'm usually able to tell, but it's important if you do that, you have to, as you mentioned, you have to get a baseline before you maneuver or you put a clip. Get an insonation with the Doppler, get your baseline ICG fluorescent. If you are likely to have the flow probe, you can measure the flow, but it's critically to do it before, so you have a baseline. And I must say that with the Doppler, after so many years, I can usually tell if the vessel might be open on ICG, but I can tell. But that's a point to reemphasize. And it's funny, over the years to realize that some of the critical things that we all have learned through trial and error, quite often are well known to the masters. It's just that it's an emphasized comment or a single sentence. And, listening to your presentation, there were so many pearls that, and that's the reason why I felt the importance to re-emphasize and repeating so that the younger colleagues, they can get the most out of this and don't have to go through the same motions that we have gone to, doing something, observing something, and then you go back and you read what he has written and say, oh, it's here, but it's one sentence.
Yes. It's the nuance that, you pick up as much as you can during training, but it's experience that teaches you, unfortunately, sometimes with bad experiences. One of my mentors said, experience is your last case, and it holds true. You learn from each and every one. And Spetzler used to say when I was a fellow, you would watch him do some amazing case and you would think, oh, I can never get to that point. And he would say, no, you're just not as good as you're going to be. And that's holds so true, that you grow and evolve as you go through your career. If you're careful and you look at your results, and especially your bad results, and really ask yourself what you could do differently, we grow.
And, like with aneurysms, and I mentioned before, I learned that when I started with my practice, you go through the operation, the exposure. There is a point where you think you have enough and you are tempted to put a clip. And those are the times where now I realize it was because of inexperience. I end up with a bad result, and the importance, of doing your homework, exposing, freeing that neck, even though you do take a chance, especially in a ruptured case. But once you have proximal control, it's critically important to have a full understanding, separate that arachnoid around the aneurysm, free the neck, and have a good view, especially where you know that perforating vessels are going to be. So let me see. If I open the folder, still cannot see it.
Something is, I think, it might be because of the hospital.
Yeah, the Mayo system. There are so many firewalls that there is always a significant lag, and I think with what happened yesterday, it's even more so. So that's fine. I think we can reserve. We are planning to do this on a monthly basis. We can reserve your cases for next time. I like to.
Okay. Again, I apologize for that.
It's we are lucky that we have your presence and your words of wisdom. I like to thank everybody, the participants, but particularly the panelists for their generous time. And once again, I cannot thank enough Imadullah for making all of this possible and for being here with us on a Saturday. Thank you very much.
Thank you. It was fun.